welcome to Dr. J's Prescription for Health. I am your host, Dr. Malea Jensen. This is your opportunity to ask health-related questions and get those answers, hopefully. If I know the answer, I will let you know if I don't. Okay, where should we start? How about we start this off by talking about the Dodgers and the Blue Jays tonight. It is the deciding game 7. Winner takes all tonight. So for all of my Canadian friends, I respect that you are going to go for the Blue Jays, and I think this is a good competition between USA Dodgers and the Canadian Toronto Blue Jays. So I wish all of my Canadian friends good luck, and all those who are rooting for the Blue Jays. I mean, there's Blue Jays fans in the USA as well. So yes, I am going for the Dodgers, and I want to thank one of my listeners so much for providing me with some Dodger apparel, and they have also forced me into putting into a pile several older items that I need to get rid of. So this is I promised you guys that if I receive something in the mail, that I will get rid of one piece of my apparel that's older and replace it with the new apparel. Good morning, Lucy. Good morning, good morning. You're ready to go. She's ready to take notes. Who are you guys going for? Put in the comments who you're going for tonight. Are you going for the Blue Jays? Are you going for the Dodgers? Or you don't care? All right? Good morning, other Lucy. Good morning, good morning. We'll start out today. If you guys got questions, please chime in. Don't hesitate. No question is a dumb question. In fact, if you ask a question, somebody else might have that exact same question and just was afraid to ask it. And I don't want that. I want you guys to feel, I want you to feel comfortable asking a question in front of people. If that's how we learn, you guys. There's going to be somebody that probably is going to push your buttons a little bit and, make you feel dumb, but it's okay. We're going to get some thick skin today and in the future, and we're going to keep going, and we're going to ask questions because we all want to learn. So the first thing I wanted to talk about today, unless you guys have other questions, is something that came up. Lucy says, I'm here in LA. I should be a Dodger, but really don't care. It's okay, Lucy. Not everybody is a sports fan or fanatic or even a baseball fan. And maybe I'm kind of one of those fans that becomes a fan toward the end of the season. I don't take a whole lot of time during in season to watch sports. I just don't. I don't watch a whole lot of TV. So yeah, maybe I'm a fair weather fan. If it was the Yankees, I'd be rooting for the Yankees. If it was the Braves, I'd be rooting for the Braves. If it is the Dodgers, I'm rooting for the Dodgers. Those are my 3 teams. I know it seems odd, but I got one from every. I just don't have one from is it the National League East? I can't remember the National versus American, but I got one. I got 3 out of the 4 covered. Ruth says daylight savings time. What about it? Is that today? I'm not sure. Lucy says both. Let the best team win. Healthy competition. I'm not popular in my Dodger household. Oh, that's okay. Well, that's okay. All right, so let's talk about GERD. All capitals, GERD. Gastroesophageal reflux disease. What is it? Let's just talk in simplistic terms. When we eat something, it goes from our mouth down our esophagus and then dumps into our stomach. When it is about to dump into our stomach, the food that we've consumed bypasses something called the lower esophageal sphincter. The lower esophageal sphincter is a muscle, and it's like a little door. So if food is coming in and it's going down the esophagus, it's going to it forces the door open, okay? I don't want to say forces, the door recognizes that there's something coming in and it opens. And then the food dumps into the stomach where it can be digested even more than it already has been. Okay? Then the lower esophageal sphincter is supposed to close. That is to prevent backflow. We don't want backflow from the stomach back up into the esophagus. That is reflux. You may feel it. It might feel like heartburn because it's a burning sensation, and it burns because the pH of the esophagus is not the same as the pH of the stomach contents. So the stomach is got a pH of 1 to 3. The lower esophagus pH is above that. So when the esophagus feels that, it burns, and you might experience it as heartburn. Now, not everybody feels reflux symptoms. They don't feel that change in pH. They might only experience it at night because you're laying down and there's no gravity to keep the stomach contents in the stomach. So it's like free flow back and forth. So it's splashing up there all the time. It even can come up as high as that it goes back into your mouth. We call that brackwash, or you guys experience as a sour taste in your mouth. That is stomach contents. When that stomach content with that acidity gets into that lower esophagus, it can cause changes. The changes of the lower cells can cause cancer. And it first changes those cells to something called esophagus. Barrett's esophagus is like a pre-cancer. And most doctors treat Barrett's esophagus with a PPI, a proton pump inhibitor. The proton pump is what secretes hydrochloric acid. So it's proton pump is a hydrogen ion, and it determines the acidity of our stomach, okay? When the stomach contents are splashing up, and over time, this causes a problem, not everybody gets cancer, okay? But it is a strong possibility. Now, why or what decreases the tone of that lower esophageal sphincter? What lowers the tone? What makes the door not close after the stomach contents dump into the stomach? Why is there splashing going on? That door should close. It should close. Immediately after food is done, it should be like a trap door, and it closes. But things that decrease that tone is caffeine, smoking, alcohol. There is some thought that peppermint or spearmint might do it. Onions, garlic, some citrus fruits, some medications like asthma medications. So even some blood pressure medicines like amlodipine. Amlodipine is a calcium channel blocker. What about GLPs? Now, GLPs, those are like Ozempic, Wegovy, Trulicity, Zepbound. What are some other ones? Mounjaro. They're all the same. They're GLPs. GLP and GIP, sorry. So not all the same, not completely the same, but GLPs don't actually do anything to the sphincter itself. It actually puts pressure. So if I take a GLP, one of the mechanisms of keeping you from eating is to increase your satiety. That's the word. You're going to feel full longer. So it's keeping contents in the stomach longer. So if the stomach volume is going up, it's going to put pressure on that valve, that sphincter, and could allow food to go back up because of the pressure. Same with obesity. If you have a big stomach and it is pushing up, you can get symptoms or cause the stomach contents to splash back up into the lower esophagus. Same with pregnancy. The baby sitting in the pelvic area, grows, pushes up, and the pressure causes a backwash of food contents up into the lower esophagus. Sometimes a hiatal hernia can be responsible. There's a diaphragm that divides our upper torso from our lower torso, and you can get a defect in that diaphragm that allows part of the stomach to slide up in through that diaphragm. Now, not everybody who's got a hiatal hernia will have reflux. Not everybody who's got reflux will have a hiatal hernia. But that is one other mechanism of reflux. So what is the treatment? From a conventional standpoint, from modern medicine standpoint, we want to lower, or the goal is to, the goal, I think, from a medical modern standpoint, is to change the pH of the stomach. So somebody else mentions baking soda, okay? Now, it could be baking soda, it could be a proton pump inhibitor, it could be a histamine blocker, an H2 blocker. But let me tell you what is going on. If we change the pH, that's our goal from modern medicine. And we've taught you guys this. We've explained to you that if we simply change the pH of our stomach contents, that if it does splash up, you're not going to feel it, and it's not going to cause Barrett's esophagus or esophageal cancer. So as a doctor, you tell us the symptoms. We may or may not have looked down there or referred you to someone who looks down there. Because a lot of times, if you've had these symptoms for a long period of time, I'm going to refer you to a GI specialist. I'm going to refer you to the GI specialist, and they're going to do an upper GI or an upper endoscopy. So they're going to take their scope and look down and see, one, what the pH is. Two, they're going to look at that lower esophageal sphincter. And they're going to determine, hey, how long has it been going on? Do you have Barrett's esophagus? Are there signs of esophageal cancer down there? Changes in the cell structure. A lot of times, you go to your primary care doctor, and they will put you on a proton pump inhibitor. Omeprazole, Prilosec is the other name, Z-Grid, Protonix, Prevacid. Those are proton pump inhibitors. It is inhibiting a cell in the stomach area from making acid. You are being prevented from making acid. If you don't make acid in your stomach, the pH will go up. Normal pH in your stomach is between 1 and 3. Why? God made us that way, and we need it that way. That is how we keep a sterile environment, nutrients like amino acids and minerals and vitamins like calcium and magnesium and selenium and zinc and iron, just to name a few. It needs that pH. So if we change the pH by giving a medication, or like the person who said, I can just take baking soda and I'll be fine. Well, baking soda also changes the pH. You're telling your maker, your creator, that they made a mistake. So what you're actually saying is, they made a mistake, your creator made a mistake, and they messed up your pH. No, they didn't. Your creator did not make a mistake when they made your stomach pH between 1 and 3. The doctor never tells you why you have splashing. Why is that lower esophageal sphincter not working? By the way, you guys, I am live on Instagram and YouTube. If you are on YouTube right now, I would suggest to you, if you want your questions answered, to jump over to Instagram, okay? Because we have trolls, we have rude people on YouTube that simply want to distract from the others. But over time, they're actually doing me a service right now, but over time, they will get tired of being here and they will find somebody else. It's a great game. It's not going to work. So you guys, if you want to go over to Instagram, you've got questions, I'd be happy to answer them. So just like the individual on YouTube states, I'll just take some baking soda and solve the problem. But as we change the pH, as I mentioned before, we are changing a normal physiologic mechanism. Thanks, Hammer Time. You're going for the Blue Jays. I wish all my Blue Jay fans, I wish them well. That's awesome. Okay, when we change that pH, it is going to disturb how our body reacts. And I mentioned amino acids. So if you are eating a ribeye steak, if your pH is off, you are not going to be able to absorb all of those amino acids, if any. So your $25 steak could be worth about $5. So you've wasted it. That's simply by taking a proton pump inhibitor or simply changing the pH by drinking baking soda and water. That's the mechanism, is to change the pH as if somebody made a mistake, but they didn't. The things that are causing the relaxation of the lower esophageal sphincter is where the root cause is. Is it the peppermint and spearmint and alcohol and smoking and caffeine and chocolate? Is it the medications? But once you have Barrett's esophagus or you have esophageal cancer, it's kind of like it's almost too late. You have to take the PPI or you will, the Barrett's esophagus will continue to get worse. And I sympathize with people who have done that to themselves. But what if it was just new symptoms and your doctor sends you, they look down there and they say, whew, everything is okay. Well, we don't just treat you with a PPI. And honestly, your doctor doesn't want to send you because if they work for a corporation, that comes out of their pot. If they refer you, even if it's within the system, it is a strong possibility that a referral money, their pot goes down. So they want primary care to take care of everybody and not refer them, especially not refer them out of network. They don't want that because then doctors don't make as much. Imagine that. They won't make as much if they refer you and things are coming out of their pot, okay? The insurance company does not reimburse as high as if the doctor just refers everybody. Oh, you got a rheumatoid problem? I'm going to refer you to a rheumatologist. Oh, you got a GI problem? I'll refer you to GI. They don't like that. If you are kicking the can down the road or punting, the insurance companies, after a while, catch on, okay? And so, gosh, I mean, you would think, how can that be? Why would the doctor be like that? They don't want to deal with it. They really just want to see you for the easy things and refer you for everything else. They don't want to deal with it. They don't have enough time. They do not have enough time. They're seeing 40, 50 patients a day. They don't have enough time. That's why you guys are waiting so long to get into the specialist, because that's what primary care doctors do. If it's in Canada, it's even worse. That's what I've heard. But in all reality, if you have these symptoms, it should be looked into. Because what if you didn't have symptoms and then all of a sudden you did? I mean, how long have you not had symptoms and causing problems? It needs to be looked into. But people don't do that. And now PPIs are actually being sold over the counter. So you'll go get your PPIs and you'll stay on them forever. And if you go off, there's where the problem starts. If you go off your PPI, you're going to get a rebound of symptoms that are probably even worse than what you had before. Because when you're blocking the proton, the parietals, you're blocking the acid producing cells with a PPI. You're blocking them, you're blocking them, you're blocking them a month, 2 months, 12 months, 5 years, you've been blocking them. If you just stop taking the PPI without weaning off, you will get a hypersecretion of acid from those cells, producing a bunch of acid. And now, if you didn't fix your lower esophageal sphincter, that acid will really start refluxing up. That's why I don't want to say never. You should not go off a PPI cold turkey. You should talk to your family practice, your PPI, or excuse me, your primary care, PCP, and talk to them. Hopefully they will know how to do it, okay? But you need to wean off, even if it's been a month. That's why the packages sold over the counter are for 2 weeks only, because they hope that you won't continue to buy it over the counter. They hope that you will talk to your doctor, but they also want to make some money on the side. So if they can make some money for 2 weeks, they'll make money. That's how it works. If there is a demand, there's going to be somebody with a supply, and that's pharmaceutical companies. All right. So work on the things that is decreasing the tone of that lower esophageal sphincter. If it's obesity, you got to work on that. If it's pregnancy, hopefully it will resolve in 9 months. If it is alcohol, got to make changes. Smoking, obviously. If it's peppermint, spearmint, chocolate, caffeine, you got to make changes. What the doctor will tell you, oh, well, just elevate the head of your bed. Well, okay, that's going to improve your gravity, right? It's going to keep things hopefully down into your stomach, but it didn't solve the problem of this lower esophageal sphincter. It's almost like, and again, I have been here because these were my recommendations to people with GERD. But is it the right way? It was a defense mechanism. Don't you think that all of the symptoms we have or all of the diseases we have is actually normal defense mechanisms? I mean, if you got splashing up into the esophagus from the stomach and you get symptoms, isn't it the symptoms that is telling you about a defense mechanism? Say, hey, Joe, you're getting symptoms. Something is wrong. Oh, I'll go to my doctor, and the doctor will simply just give you a Band-Aid. We're just going to keep your symptoms. We're just going to make them so you can't feel them. Now, is that helping anything? No, it's not. So I think that's why you guys are here. You want to know what is actually root causes of these things, because I truly believe the symptoms we have are a protective mechanism. And if we are lowering the pH, in a sense, doctors are causing malnutrition. They're actually causing you guys to have malnutrition. And then, you say, hey, doc, can you check my magnesium level? Well, sure, or no, or your calcium level, or your iron level, or your amino acids, or selenium, or zinc. You just want to know. And sometimes the doc just won't check them. But if they're low, let's just say they're low, the answer to that, in your standpoint, is just to take whatever's low. So if magnesium is low, you'll take magnesium. If the zinc is low, you'll take zinc, selenium, whatever the thing is. Or, oh, Dr. Jensen, you said that my amino acids might not get absorbed. Well, I'll just go take some whey protein powder. I'll get my amino acids up. Well, that you can take all you want, but you're still not going to absorb them because the pH isn't right. Make sense? So you're getting malnourished. Okay? Another thing that PPIs, that when the system changes, the pH changes. And by the way, greetings to you, good-hearted Pearl from Uganda. I appreciate you being here. Been to Uganda once in 2000 and I think it was 2008. Yeah, I was in the June of 2008. I was there for on a ministry, so missionary trip. What is the consequences besides poor absorption of these vitamins, minerals, amino acids? What could possibly be downstream? Well, one of those is dementia. Did your doctor mention that you could increase your risk of getting dementia by taking a proton pump inhibitor? Likely not. Why could that be? Well, if you decrease the absorption of iron because you've changed the pH, the brain cells need iron, they need magnesium, they need all of these selenium and zinc, they need that. So that repercussion in the brain is to cause cognitive decline. So what if you're on a proton pump and inhibitor, and you're on a statin, and you have diabetes, and you got sugar overload? Can you imagine your increased risk of cognitive decline? And you have been taught to think, oh, it's all hereditary. It has nothing to do with the medications that you're on, with your diet, because your doctor never told you. Your doctor never went over everything. Again, that's why I think you are here. Omeprazole is a PPI, so I thought. Omeprazole is Prilosec. It is a proton pump inhibitor. Yes, Beth. Let's see. What is another question here coming in? Yes, there are many things that can cause cognitive decline. I'm just talking right now in terms of PPIs and why a PPI could cause that. They can also cause problems with bone demineralization. So you're a setup for osteoporosis. Why? Because it leaches calcium. If you take a PPI, you change your pH, you make it higher, so less acidic, not alkaline in alkaline, so to speak, because alkaline is over a pH of 7. I doubt we're getting there, but I have seen PPIs drive up the pH of our stomach contents to 4 to 6, when the pH should be 1 to 3. But if the pH changes enough that we now can't absorb calcium, now how are we going to get calcium for the things that all cells need calcium for the calcium channel? If we don't have calcium, where's the calcium going to come from? Bones and teeth. Oh, I'll just take more calcium. Can you absorb it? Can you absorb it if your stomach acidity is not right? Probably not. Oh, I'll just take some vitamin K2. Well, why don't you just stop the statin? Well, I'll probably have cognitive decline because it's hereditary. No, it's not. You might have a gene, but you have to feed the gene. What about, so we talked about, cognitive decline or dementia, osteoporosis. What else? I mean, if we're decreasing, I talked about malnutrition. Talked about, here's a big one. If we were if we change the pH of our stomach contents, right? We're going to increase the pH. I want you to think through stuff. What about our increased risk of cancer in the stomach? So gastric cancer. In my right now, what I believe is cancers love an alkaline type environment. They like alkaline, and they like no oxygen. Those are some of the ways they ferment. So cancers ferment, but that's just one of the ways that cancer develops. So if I'm changing the pH of my stomach contents, I could be increasing my chances of gastric cancer. I learned about this years and years ago when I believe it was when Nexium came out. So Prilosec is omeprazole, and Nexium is esomeprazole, meaning it's the mirror image, it's the isomer of these things. And we've done this with all kinds of medications. Pharmaceuticals have done this with medications. because the patent runs out. If they're going strong, selling Prilosec before it goes generic. So Prilosec. Then it goes generic. The patent ran out. There's less money to be made. And then it goes over the counter sometimes. Or it's just simply a generic, which it is. So that pharmaceutical company has been busy making just a small change in that medication. Zyrtec did it. Hydroxyzine was the old Zyrtec. So they changed hydroxyzine just a little bit. And now you got Zyrtec. And then Zyrtec made a bunch of money, and then it goes generic. And then it goes sell over the counter. But some other drug company, pharmaceutical, probably picked up that patent and to sell it over the counter. It might not be the original maker of Zyrtec. So the makers of the Zyrtec pharmaceutical company then does some studies, does this, and makes a whole new medicine called Zyzal, Zyzal. That is a souped up Zyrtec. It is an isomer of Zyrtec. They changed one little thing on the, Cal, I'm sorry if you don't have Instagram. You got time right now, maybe put a Q in front of it and I'll try to answer it if I know the answer. But these patents that run out, and so that is Prilosec and that is Nexium. And so they're going to continuously be on the market for stuff like that. If there's a supply, a demand, there's going to be a supply. And pharmaceutical is into, they want to make money. I mean, that's how they grow. Okay, so the gastric cancer, the dementia, the osteoporosis, increased risk of esophageal cancer. Did you guys have any questions on that? I've just been, I'm reading, I took notes this morning, and those are some of the things that I wanted to go over. I really love some of you guys over there on YouTube. Beth says, I don't know what, Beth is talking to somebody else. Okay. You guys are answering each other's questions over there on YouTube. Awesome. So if we don't have any further questions on gastroesophageal reflux, let's move into something that I love to talk about, and it's insulin resistance. Insulin resistance. When something, a cell, is exposed over time constantly to a substance, it will become resistant to it. Let me give you an example. If you take Benadryl for sleep, at first the Benadryl works, it's working. It's going to improve your sleep. You're going to just fall off to sleep. The thing with Benadryl that most people don't know is it never puts you into deep sleep. It's superficial. It's almost like going out and drinking, and you say, oh my gosh, if I just drink, I get so tired, and the minute my head hits the pillow, I fall asleep. But it's not, you're not going into all of the waves of sleep. You are basically getting a superficial sleep, and so you never get restful sleep, never going into deep, restful sleep. Same with Benadryl. But that's beside the point. The fact is, when we keep taking Benadryl over time, we either, one, have to increase the dose because it's going to take more to stimulate those receptors, because the Benadryl receptor, or where Benadryl attaches on the cell, starts to downregulate. There becomes less Benadryl receptors, and they kind of close their doors. They become resistant to the Benadryl. So it's going to take you going off of the Benadryl, and then the receptors will upregulate it again. So the next time, say you did a week or 2 weeks, you allowed the little receptors to upregulate, because right now they're downregulated. They're going to go and upregulate, so there's going to be more of them. Now you take Benadryl and you crash. Okay, so same in a way with insulin resistance. Insulin is needed in our body or we would die. You would die if you do not have insulin, okay? Okay, so if you don't have the insulin, which we all need, you do die. But what is happening is we actually have too much insulin. So a part of being insulin resistant, so if there's too much insulin, those cells, receptors, basically lack sensitivity to insulin. They're not listening to insulin anymore. And the insulin is not talking correctly either to the cell. So could there be a problem with the insulin itself? Absolutely. Could there be a problem with the receptor? Yes. But the main causes of insulin resistance is hyperinsulinemia itself. High insulinemia in the blood, high insulin in the blood. What else? I believe there's 3 main causes: hyperinsulinemia, inflammation, and stress. And you guys could say, but what about sugar, like carbs? You keep talking about carbs, they're a cause of insulin resistance. Or what about heavy metals or alcohol or smoking or nanoplastics or all of the things, you always talk about these. I do, but they're not the main causes. If you have carbs on board, okay, carbs are going to increase blood sugar. Blood sugar is going to continuously raise insulin. So that goes along with the hyperinsulinemia part. What causes inflammation? It could be smoking and alcohol or heavy metals or nanoplastics, and that is causing inflammation to the cells. And that is the main cause of insulin resistance. Or what about stress? Well, it could be no sleep. It could be you got to take the kids all over in the place, and you're in traffic and all these things. That increases stress. But the stress is actually the cortisol and the epinephrine that's going up. So the 3 main causes of insulin resistance is hyperinsulinemia itself, inflammation, and stress. And then things can increase stress. Things can increase inflammation. Things can increase hyperinsulinemia. Got it? Now, an example, and this might answer some of your questions, I see it on YouTube, and an example of insulin resistance, because the question is, what cells get worse the fastest? And I would agree with a number of physicians online or PhDs online. I would agree that the cells that first become affected by hyperinsulinemia or insulin resistance is the fat cell. Many people online will say it's the muscle. The muscle becomes resistant first. That's why you get insulin resistance. I disagree. Well, what about the liver? The liver has got to be the one that falls first. I disagree. I think it could be second, but I don't think it's first. Why do I say that? I say that because if the fat cells were the ones that really fell first, the blood sugar is not going to be as affected. The blood sugar is not going to be affected as much. It may not go up. Okay? That is why we get an insulin level. An insulin, because a lot of doctors will say, I'm just going to check the glucose level. And if the glucose level is fine, your insulin level is fine. Well, you would have to accept the fact that insulin and glucose go together. They do not, and we've proved that because you could have a normal glucose. It's 70, 80, you can have a normal fasting glucose. Yet you'll get an insulin level and it'll be 20. And you have obese fat cells. They're big. Your liver function may be okay, but I will tell you it's not. But your muscle might be okay, but I will tell you it's not because you have muscle fat, you have liver fat, and doctors are not looking for that. So let's go back to why I feel that fat cells fall first and not liver and not glucose is because if the liver became resistant first or even second, well, let's just say first, if the liver became insulin resistant first, the blood sugar would be sky high and you would know it. If the muscle fell first, the blood sugar would also be high because the muscle takes in so much glucose. When your glucose is dropping down, like it goes from you ate something and it's at 150 and then it drops down to 90, the thing that dropped it so quickly was the muscle took up. It is a hungry organ. The muscle is. If you got it, it is hungry. It's going to take it in until it can't. So insulin tells, what is the purpose of insulin? It is not simply a hormone that only works with blood sugar, but I want to tell you that insulin's job is to tell cells where the energy goes. Where is the energy going? If you consume something, a food, I call it energy, the insulin is going to tell it where to go first. It will go to the fat cells. Insulin also tells the liver what it's going to happen. Insulin is a talker to all of our organs. It will talk to your liver, and the liver is going to start taking up HDLs out of your bloodstream. And so that is why the doctors who are educated in metabolics will say, I think you have a metabolic problem, without even looking at an insulin problem or the insulin level. How? Because your triglycerides will be elevated and your HDL will be low. And insulin is what's doing the talking, okay? It told the fat cells to take up some energy, but sometimes they can't get any bigger. The insulin tells the muscles to take up some energy. And it tells the liver to take up some energy. When the liver takes up the energy, it's talking to things in the bloodstream as well. That is reflected in the HDL level. So if you have a high triglyceride level and a low HDL level, you have metabolic problems, whether or not you get an insulin level or not. I would tell you that your insulin level is high. How high? I don't know. But it is. You are insulin resistant. The fat cell is the first one to become resistant. It is a protective mechanism of that cell not to take in more energy, or else it's going to explode. Think of a balloon. You keep putting water in her, air, more and more, it's going to pop. The fat cell feels the exact same way when it gets too big. And so the protective mechanism of a fat cell is to stop taking in more energy. So it talks to insulin and says, I can't do this anymore. So it shuts the doors on the cells. It decreases the amount of insulin receptors on the cells. And insulin can't do its job. So is it a problem with the insulin or is it a problem with the cell? I don't know which came first. I really don't. But I'm just trying to explain a mechanism of what could possibly be going on. So if insulin can only go up when there is energy on board, right? And insulin is needed to drive energy into the cell. If the receptors aren't working, no energy goes into the cell. So let me give you an example. I know this can sound confusing. I want to explain to you why we need insulin. You know, if we don't have insulin, you would essentially be a type 1 diabetic, right? Because type 1 diabetics don't have insulin. If we don't give them insulin, they will eventually die. So it's not how many calories or the type of energy, so to speak. We're just going to keep this simple. It's the amount of insulin. It's insulin in general. What I mean by that, if you are a type 1 diabetic and you eat 10,000 calories right now, and you do not give insulin, you cannot grow bigger fat cells. Remember, insulin is needed to tell the energy where to go. If there is no insulin, you will continue to lose weight. You will have such high blood sugars that you will get ketoacidosis. But some type 1 diabetics are so good at dosing their insulin in order not to get fat, especially people who have what we call diabulimia. It's like bulimia by not giving themselves insulin. I've seen girls who are very good at this. They're type 1 diabetics. They know that if they just don't dose their insulin, they won't get fat. They'll just pee out blood sugar. They'll eat, like I said, 10,000 calories. And they'll be all, their friends will go, oh my gosh, I can't believe you can eat that way and never get fat. No insulin. They could die. They could go in a state of ketoacidosis. But yeah, they're not going to get fat. What is an example that maybe you guys can relate to, you've heard about when it comes to insulin resistant? I want to give you another example besides just growing fat cells fatter. All right. The one thing that you guys might relate to is infertility, or, well, I guess it is infertility. Infertility, as far as a man is concerned, I would speak to the fact of erectile dysfunction. If you can't get an erection, it is much, much harder for you to fertilize a female, okay? It's harder, obviously. That erectile dysfunction is likely the first sign, second sign. The first sign was hyperinsulinemia. The second sign could be, in a male, erectile dysfunction. So if men would come to me back in the day, and they would want something called Viagra or Cialis or whatever it might be, okay? I would be giving that man basically a Band-Aid. And I usually did that, but without complete understanding of what is causing his ED in the first place. Erectile dysfunction. The mechanism of an erection is for the blood, the arteries, to vasodilate. When the artery in the penis vasodilates, blood flow goes in, erection occurs. Insulin is needed for that to happen. Okay? So without insulin, that process would not occur. If insulin is too high, hyperinsulinemia, which is insulin resistance, now insulin can't cause the arteries to vasodilate. Makes sense? Let's just go just a little deeper. Insulin is needed for the cells of the lining of the artery. They're called endothelial cells. Insulin is needed to stimulate the endothelial cells to release nitric oxide. Nitric oxide is what causes the arteries to vasodilate. If there is too much insulin, that means the endothelial cells become resistant. They stop talking to insulin. They needed insulin to work, but now there's too much, so they clam up and they say, endothelial cells says, Mr. Insulin, there's too much out here. I'm clamming up, and now guess what? You don't have, those endothelial cells don't have insulin to tell the release of nitric oxide. Nitric oxide needed to vasodilate, so now you just say vasoconstricted, so to speak. So if I would have been smarter back in the day, instead of just, and I truly wanted to help them, because if you're a man and you are unable to get an erection, you identify that with yourself and you feel like a failure, and then it leads to depression, and it leads to, but something was causing the erectile dysfunction. You might say, oh, you know what? I'm just getting older. No, that's not the case. Age had nothing to do with it. Your arteries could be getting worse, yes, but what from? They're getting older faster? Maybe, but why? Could it be inflammation? Well, what caused the inflammation? Could it be stress? Well, what caused the stress? Could it be hyperinsulinemia? What caused that? I didn't check the insulin level. I didn't know about the connection of insulin and night. And that is a whole process, you guys. That is a journey of being a doctor. That's why I hate this word, but what kind of physician are you? I'm family practice. I'm a practicing physician. All physicians are practicing. To what extent are they practicing? They didn't get it all in one shot. They didn't learn all of this in medical school and then it just ends, or residency and it just ends. No, it's a journey, and I can't take blame. I can't be guilty. All I can say is, bam, I've at least opened my eyes to possibilities. But there are not a lot of doctors out there who want to admit that they could have been wrong. They don't want to admit that they don't know it all. And then they'll give an excuse like, I don't have time. You don't have time to practice getting better. You want to continue to just give a PPI for the GERD and not really tell the patient why they have GERD. You just want to give the male with erectile dysfunction, just give them a medicine. I know for the male, when you're right at that moment, you say, doc, just give it to me. I don't care what the cause is. I think you do care what the cause is, but really your first thought is, give me something to make it better. But what if I don't have to give you something and you can make it better? Okay? There are times when you give Viagra or you give Cialis and they don't even work. Why? Because there's no nitric oxide. That tells me that person is really, really insulin resistant. Viagra and Cialis can only work if nitric oxide is present. They cause the stimulation of nitric oxide release. But if there's too much insulin is making the endothelial cells close their doors. We need to be checking an insulin level. Doctors, are you listening? We need to be checking insulin. We need to tell the patient that if their insulin level is high, even though their blood sugar is fine, they are diabetic and waiting. They have underlying diabetes. The symptom of ED in a male is the first sign of insulin resistance, and we're not checking. And even if they did check, they don't know what to do with it. They'll say, oh, your insulin is high, but your A1C is fine. I could go into that too, what causes altered A1C. Their blood sugars are fine. Well, they don't have diabetes, so here's your medicine. They're not thinking. You guys are thinking. You're asking questions. You're going, wait a second. Now, let's turn the tables a little bit. Let's talk about a female. Let's talk about the symptoms of infertility in a female. How is she infertile because of insulin resistance? That is called PCOS, polycystic ovarian syndrome. How do doctors diagnose PCOS? Their instinct is to get hormone levels. Their instinct is to check a blood sugar level. And we've been taught that the treatment for PCOS is to put the female on metformin. What does metformin do? Metformin increases the sensitivity of muscles to take in blood sugar. It works by tries to work by opening the receptors on the cells. It wants to tell, say, the muscle cell to open the door receptor so sugar can come in. But what is the underlying cause? Why is it that the doctor will simply just give metformin, which forces the blood sugars into the cell? What is causing the high blood sugar? Is it your diet? Is it you have carbohydrate toxicity? Exactly. If we were to just simply tell the person, I need you to go low carb for 30 days, 60 days. Is it possible that that woman can become fertile? Is the woman got polycystic, many polycystic ovarian cyst syndrome? Why? Because she needs estrogen. The cysts are growing on her ovaries because the body of the female desires estrogen. Well, why doesn't she have it? Good question. In a female, all estrogens, E1, E2, E3, comes from testosterone. All estrogens arise from testosterone, from androgens. All estrogens arise from androgens. So if you were to look at the pathway, one side of the pathway is pregnenolone, comes from saturated fat and cholesterol. So cholesterol helps us to produce pregnenolone. Pregnenolone talks to the adrenal gland on one side of this situation. Pregnenolone talks to the adrenal gland and tells the adrenal gland to release DHEA. DHEA. DHEA is converted to androstenedione. Androstenedione is converted to testosterone. And testosterone tells the ovaries, if they're working, there's a couple of in the ovaries. It needs aromatase. If insulin is too high and we have insulin resistance, it blocks the conversion of testosterone to estrogen. So estrogen becomes low in the female, and we need estrogen in order to become pregnant or fertile for eggs. And testosterone will, or the androgens, will go up sky high. So now this woman with sky high androgens is going to get hair growth. She's going to get all of the symptoms of having male pattern, blah, 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 whatever the testosterone does for the male, it's starting to do in the female. And one of those things is she can't get pregnant. She doesn't have enough estrogen. So what does the doctor jumps in, kind of knows, maybe doesn't know the exact mechanism, but jumps in and says, oh, I know what I'll do. I'm just going to give you birth control pills. You're not ready to get pregnant, but you're getting all these symptoms. We've diagnosed you with PCOS. I'm just going to give you some estrogen, and I'm going to give you some metformin. And we never once talk to the woman and say, or the child, because 13, 14, 15, they're getting PCOS. They got it. They got fat growing in places where they don't want fat growing. And you chalk it up to, oh, she's just going through her puberty stages. Of course she is. She's got PCOS. She's been eating a crapola diet for years, and the parents fed it to her, and she is insulin resistant. She has hyperinsulinemia. No one thinks to check the insulin level. No one wants to change her diet, but they'll put her on birth control pills, and they'll put her on metformin, and they'll get rid of the hair growth, and they'll get rid of the whatever. May or may not be able to get pregnant, but she doesn't want to right now. So we're going to expose this little girl to birth control pills for years and years and years until she decides that she wants to have a baby. And we've ruined or helped to ruin or just made inactive her normal hypothalamus, pituitary, adrenal axis. We've wrecked her natural hormone axis from the hypothalamus to the pituitary to the adrenals, all of that pathway I was talking to you about. The pregnenolone talks to the adrenals to make DHA, all of that. And we think we're doing our girls, well, her periods are bad. Well, her periods are bad for other reasons. Her periods are crampy, maybe because she's got iron overload. She's got to get rid of some blood, because she's overloaded of iron. That's a normal mechanism for us women to get rid of iron. Men don't have that. They just get iron overload and there's nowhere to get rid of it except I'll just go dump blood. You can see that we do the things, it's like a Band-Aid, not knowing what the actual cause is. Is that really medicine today? This is what I struggle with, you guys, and with my career, all this, going on. We would rather not treat the man with ED by telling him what caused it. We would rather not treat the PCOS patient by telling her what's causing it. But we will go and do things as if it had no consequences. What is the consequences of giving Viagra or Cialis to a man with ED? Well, if you're going to cause vasodilatation, is it possible that you could cause vasodilatation somewhere else? Like, what if your heart was constricted and all of a sudden you vasodilated it and you just caused a rush of blood into there? Could you have caused a heart attack? Yes. What about a stroke? A hemorrhagic stroke? Have you heard of people, men, older, however age, where they take Viagra or Cialis that was given to them by the doctor and they died during Intercourse? Yeah, I've heard of it. Has one of my patients actually done that? No. Is there a risk for strokes? Absolutely. Does the doctor talk to you about that? I don't know. You'd have to tell me. I do. I said, are you sure you want to do this? It may or may not work. You might not have any nitric oxide. I didn't know that you had to check the insulin level. I don't know that there are many doctors who know that. We got diabetes. We give metformin. We give GERD. We give a GLP like Ozempic or Mounjaro, a GLP GIP. Did we talk to the patient why they need those medications? In fact, the medications will stop working. They'll stop working. Oh gosh, you know what? We maxed you out. We maxed out your metformin. We maxed out your GLP. We can't really go any higher. It's not working. The Jardiance, it's maxed out. We're just going to have to go to insulin. Well, doctor, did you check the insulin level? Well, no, what would that tell me? Well, if you have insulin and it's high, do you just give more? I mean, I would have done that back in the day because I didn't know. But now that I know, so how do we educate these doctors? How do we say, doctor, do you give more insulin to somebody who's got hyperinsulinemia? I mean, does that sound like, do we give an alcoholic more alcohol to get rid of their alcoholism? I mean, that's how dumb this sounds. But doctors don't think of it that way. Well, they just need it, and their blood sugars are way too high. Well, then tell them to stop putting the blood sugars so high. Well, how do you do that? Really? I have to ask that question? Doctor, what causes blood sugar to go up? Well, the most obvious reason is what they put in their mouth. So let's just say the doctor gives up and says, I don't want to talk about that. I don't want to talk about their sleep. I don't want to talk about their stress. I don't want to talk about their inflammation and their high insulin. I don't want to do those things. I'm just going to give insulin. Well, guess what? It's going to need more and more insulin. I have had patients who come to me from other doctors who are on 90 units of insulin. 90 of combination of long-acting insulin and short-acting insulin. And they wonder why they can't lose weight. They wonder why they have so much fat on them. They wonder why their belly is protruding like a pregnancy and they have skinny little legs. Or skinny muscular legs. They have Wagyu beef muscles full of fat and no strength. You would think when you look at some of these people who have insulin resistance and they have all of this belly fat, they have this big protruding abdomen, and they have these they've never lifted a day in their life, and their muscles in their legs, like their quads and their calves, are humongous and perfect shape. That's Wagyu beef. Their muscles are so full of fat because insulin drove sugar, glucose, into the muscle cells, and fat grows ectopically. That's what liver fat is. It's ectopic fat growth. Is 90 high for okay, one, let's answer your question, like what is normal insulin level, or what is optimal between 1 and 3? Why is 1 to 3 optimal? Because the normal optimal amount of blood sugar that is in our body, so we have in the average size human, we have about 5 liters of blood. And in that 5 liters of blood, we have about 5 or 6 grams of sugar. It's a teaspoon of sugar is what is needed for our body to survive. So it needs, for that 6 grams that 1 teaspoon of blood sugar, we need about an insulin level of 1 to 3. But when we check people's blood sugars, if they didn't have insulin on board, or if we weren't giving them insulin, their blood sugars could be 200-300. And so we will dose the appropriate amount of insulin, whether it's right or wrong, we would dose the appropriate amount of insulin to cover 300 of blood sugar. And so, yeah, 90 units is very high. If we were to, let me give you an example. If we were to give about 10 grams of carbohydrates, so you had 10 grams of glucose on board, a doctor would most likely dose the patient as far as insulin with a unit of insulin, okay, for every 10 grams. So if you eat 20 grams of carbs, you need about 2 units. If you were eating 100 grams, you need, more insulin, right? It's just going to take more and more insulin for how much. So if somebody's needing 90 units of insulin and it keeps going up, it may not be because, I'm going to backtrack. It may not be because their blood sugars are, or what they're eating is the problem. It's just that the person has kept their blood sugars at a level and it's requiring more and more insulin to bring it down. And so if I were to tell the type 2 diabetic, stop eating carbohydrates, then less insulin is going to be needed, because if your production of insulin is coming down because it's not needed, then less insulin is going to be injected. See, the doctor is giving insulin when that was not the treatment. You don't give more insulin to a hyperinsulinemic patient. You're making them more hyperinsulinemic. It is the wrong treatment. It is contraindicated. The treatment would have been to tell the person to lower their endogenous insulin. How? No sugar. No intake of sugar, stress reduction, better sleep, all of it. Okay? That was the treatment. But we're, as a doctor, have been taught the Band-Aid, have been taught pharma. I mean, even myself, I took great pride in making diagnoses and knowing I was very, still am, very well versed with medications. I know how they work. And I took great pride in making a diagnosis and helping you get better by giving you a medication. I thought that's what doctor meant. But what I've come to realize is it's kind of like tough love, but you really need to know why you have the disease state or the symptom you have. It is a protective mechanism. High blood pressure is a protective mechanism. Oh, Dennis. See, Dennis is saying his A1C was 13. That's high. A normal A1C is 5. Pre-diabetes is 5.6 or 5.7, 5.8, 5.9. In my belief, 6.0 is diabetes. When does your doctor diagnose you with diabetes? Usually around 7. They will wait until your A1C is 7.0 or above and start treating you. But you at 7.0 have likely been insulin resistant for 10 plus years. So you have damage to your eyes. You have damage to all of your organs. Why? Because you've damaged all of your arteries. Because of the blood sugar is toxic in your arteries. So all organs, your eyesight got worse, your heart got worse, your kidneys got worse. Were they talking to you about your kidney function? No, because as long as the reference range said above 60 on your eGFR, your estimated GFR, you're fine. So you're telling me, doctor, that a 61 is fine when it should be 90? if they're at 61, they already have stage 2 chronic kidney disease. So doctor, you're letting a 7.0, not diagnosing a person until they're 7.0, the blood sugar in their bloodstream has been toxic, wiping out their eyes, wiping out their kidneys, wiping out their brain, wiping out every organ, macrovascular and microvascular, wiping out their penis, wiping out their ovaries, females. Everything is being wiped out because you are following some guideline given by someone we don't know who they are and pushing the goalpost further and further down the line. Because if you have diabetes, we want you sick, right? We're telling you, I guess I must want you sick because I'm not going to treat it, but I'll treat all the other things. I'll treat you for your cholesterol. I'll treat you for your blood pressure. I'll treat you for your eyeballs going bad. Your liver's going bad? Oh, well, I'll send you over to GI and they got this fancy new medication that can help regrow your liver. Every symptom you have, like high blood pressure, is not really the diagnosis. High blood pressure is protection for you. It's a protection for you not to have a problem. How do I say this? You have high blood pressure. Say it's 140/90, and now that's the new guidelines, and doctor gives you a pill. That blood pressure was necessary in order to feed your organs. Your brain needed blood and oxygen and all the nutrients. So your body responded because of something else. Your body responded to raise the blood pressure in order to get blood flow to your brain. I'm just going to give that one example. If I go in as doctor and give you a blood pressure medicine and lower your pressure, do you think your brain and your heart are going to get enough oxygen and nutrients? The answer, no. So what does the heart do? The heart is going to pump harder and faster. And over time, what is the repercussions of doctor lowering blood pressure, thinking they're doing the right thing? What if you lower the pressure, oxygen and blood and nutrients not getting to your brain, not getting to your heart? The heart is going to say, pump harder and pump faster. What does that sound like to you? It sounds like AFib and it sounds like congestive heart failure. So why did we get congested? Well, the doctor lowered my blood pressure. Well, I had to because they told me that a high blood pressure was harder on the heart. Well, which is it? Good question. What caused your high blood pressure? Well, now I know it's probably hyperinsulinemia. If I were to just lower my insulin, my blood pressure would go down naturally. My water retention would go down naturally, so I wouldn't have as much edema. All of the things that we call diseases basically give the doctor the right to diagnose you, make a diagnosis code, and treat you. Insulin resistance is to help you, not to hurt you. Your cells becoming insulin resistant, let's just give an example, your fat cells. Your fat cells saying, no more insulin, I am full. I'm full. I can't take any more. The fat cell was doing its job by soaking up all of the things, the fat, the cholesterol, the glucose, all of the things. The fat cell was doing its job because there was too much of it out there. So something, insulin, was driving it into the fat cell. But eventually the fat cell says, I can't take anymore. You're going to cause me to grow too big and I'm going to explode. So the fat cell becomes resistant. And so the insulin just moves on to another fat cell. But what if it runs out of fat cells to get big? And it continues to drive it in to the fat cell. Insulin drives in the energy into the fat cell. The fat cell is going to start leaking. He's going to get so big. He might not explode, but he's going to leak. He's going to leak out his innards in order to try to save himself. Because if he continues to get big and he explodes, he's going to die. And he doesn't want to die. Fat cells don't want to die. Nothing really wants to die. So if these fat cells don't want to die, they're going to start leaking out their inner contents. And some of those contents look like fatty acids. Now, in most scenarios, when insulin is high, fat cells grow. The only time that does not pertain is if the fat cells have grown so big that they start leaking out their fatty acids. They actually look as if they're breaking down fat, even in the presence of high insulin. So as a review, in order for you to be able to break down your fat, burn your fat, insulin has to be low. That way, your fat cells will start releasing or breaking down everything that's in them. They'll still stay a fat cell, but they shrink. The only time that that does not pertain, and you can have fat cells trying to shrink in the presence of high insulin, is when the insulin is so high. It's not low, it's so high. It's causing the fat cells to want to break open and leak out their contents. It's a bad situation. That person is now pushing those fatty acids that were locked up inside into the liver, fatty liver, into the muscles, fatty muscle, into the tongue, fatty tongue. It goes to places where it's not supposed to be. You would hope that fat stays in fat, but not go into areas that it's not supposed to be. Make sense? Let's see. I love talking about it. I love talking about insulin and the nuances of insulin. There are times when we want high insulin. You could say, well, Dr. Jensen, you've been talking about too high insulin is really, really bad. And I don't think there's ever a time when we would need high insulin. But there is a couple of times where the need for high insulin is necessary. And that is when we are growing. So a pregnant female is growing and she needs higher insulin. But we don't want to force her into a high insulin by giving her a whole bunch of carbs. Now we cause the baby to grow too much. And now that woman, that baby is at risk for macrosomia. Now the baby grows too big. And now we might not be able to get that baby out through the vaginal canal because their head is too big, their body's too big. They grew too big inside in utero. By the simple fact that mom ate too much blood sugar, glucose. Not maybe just during pregnancy, but before the woman even got pregnant, she could have been insulin resistant. So it didn't take much to top her off, so to speak. Now she went into the pregnancy hyperinsulinemic, way too much insulin. She's going to eat because now she's got something growing in her. And now her blood sugar, she goes, she eats to fill up that blood sugar. She's going to choose the wrong foods, obviously, right? Now insulin goes higher and higher and higher. Baby's growing too big. And now we have a baby that's going to have to be delivered by C-section. And then that has its problems in and of itself. So the other time when hyperinsulinemia or insulin resistance is needed is during puberty. A body that is growing during puberty needs, it's going to be a physiologic insulin resistance. And that's normal. The kid is growing. It's okay. But what we are doing now is feeding our kids all the wrong things in excess. And their insulin is going to super physiologic levels. We've just caused an insulin resistance in a 5-year-old. And if we have insulin resistance in a 5-year-old and the cells are getting too big, because they don't have very many yet, now they're starting to explode. Now the fatty acids go into the bloodstream. They're taken up by the muscle. There's not very much muscle. So now we got the liver. Now we got fatty liver in the kids. Lori says, is an insulin level of 18.8 high? It's very high. If optimal insulin is between 1 and 3, is 18 high? Yes, it's very high. And it's a 24-year-old female. I would venture to guess that this female is a diabetic. I would venture to guess that she has PCOS. She is going to have trouble conceiving. She is going to have hair growth. She is going to have abdominal obesity. Her belly looks really big, like she's already pregnant. Tell me if I'm right or wrong. Okay? Yes, 1. A insulin level of 1 to 3 is optimal. It's optimal. Some doctors on the spaces online, I watch a lot of people. They'll go up to 6 or even maybe 7. There's some wiggle room in there. And I like to keep it between 1 and 3. Is there a too low? That's a good question. I would say that a person who has too low of insulin, and you could even say that they're gaining weight. I mean, you could stretch that, is you find a person who is gaining weight, so getting fat, despite the fact that their insulin level is 1. I would tell you that it's not really the insulin problem as much as it is under eating. When people want to lose weight, they'll either stop eating or eat, or let's just say it's a carnivore. Let's just go there. Let's just say that this person has been told that eating carnivore, eating no carbs. Let's just go with that. We got to get some definitions straight. Keto definition, we're just talking about carbs. Keto is 20 grams of carbs or less. Ketovore, 10 grams of carbs or less. Carnivore, 0 carbs. 0 carbs. I don't care what you're eating, it has to be 0 carbs. So does that look like animal-based? Most likely. Most likely. If you are carnivore, you've been carnivore, and all of a sudden you have reached a place where you're kind of eating the same foods. You're carnivore. You're eating 0 carbs. Yet you start noticing some fat accumulating. And right now, the carnivore space is saying, just add back carbs. Well, in your memory, you know that when you were eating carbs, you got into the position where you needed to be on a carnivore diet. You needed no carbs, and then you got successful. And now you've been doing this, and now you're starting to see things creeping on, some fat. My most likely scenario is you are malnourished. You are undernourishing yourself. You might have even went very, very high of fat and not enough protein. You could be protein malnourished. Well, how much protein do I need? Ideally, you might need about 1 gram per pound of body weight. Ideally, if you're working out, you might need a little more, 1.2, 1.3 grams per pound if you're really working out. So the people who say I failed on carnivore could have been undernourished for a year or more. They're just not hungry, so they don't nourish themselves. So we call it metabolism. Your metabolism is naturally going to shut down. You're like a hibernating bear. And you blame it on being carnivore. I don't think that's the case. You're undernourishing. You might not be sleeping. You might be stressed out. You might be under the influence of nanoplastics and heavy metals, and you might even be smoking. You might be drinking alcohol. I doubt it. But these are all the things to take into consideration, okay? So Lori says, most of those symptoms you mentioned are happening. Can this get corrected through diet? Absolutely, Lori. Stop the carbs. If you stop the carbs, less glucose on board, insulin is going to come down. Insulin is stimulated by sugar, glucose, or fructose, or lactose. It's stimulated by sugar. If we lower sugar, we're going to lower insulin. When insulin gets back down to 1 to 3 optimal level, we are in a fat burning state. And then that woman now becomes potentially highly likely to become fertile. Her PCOS goes away. Now she's able to convert testosterone to the estrogen she needs in order to make a fertility situation. She needs estrogen. But we doctors, we just go, oh, here's your birth control pill, but I want to get pregnant. Just do this for a little bit, and then we'll go off, and the estrogen will be high enough, and now you can get pregnant. Maybe, maybe not. But is that really the treatment? Now you are insulin resistant, PCOS. You're already insulin resistant. And then we give you something like metformin to get you pregnant. Insulin never went down, right? It's still high. I'm just going to give you a little metformin to make the cells take up the blood sugar. So I'm just going to shift. I'm going to put the sugar from the right pocket to the left pocket. And we think in our mind that the sugar, it must have gotten less. It did not get less. It just went from one pocket to the next pocket. It didn't change the level. So now you take a woman with PCOS, with high insulin, you never managed the insulin. Now you just made her a candidate for insulin in pregnancy. What does insulin do in pregnancy? Causes baby to grow. Remember, I told you that high insulin causes things to grow. So she's not only going to gain a lot of weight, the baby's going to grow a lot of weight. Insulin is anabolic. It causes things to grow. Causes cancer to grow. You don't want cancer to grow? Stop the blood sugars. Why feed it any blood sugar? Why give it a bunch of, why feed it full of an alkaline environment? So yes, Lori, it can be corrected through diet, but the person needs to be educated. The 24-year-old needs to be educated on why they have those symptoms. If they really want, I think, well, I can't think. So, you guys, why? I don't think that a woman necessarily wants to harm her baby and in utero. And maybe she would find, if we educated her and she had enough information, she would maybe make the right decision. Maybe she would want to make some changes if it was for her baby. Maybe she doesn't want to make the changes for herself. She's reached her limit. She says, you know what, I'm over it. Lori says, you're brilliant. Thank you. No, I'm not brilliant. I don't even know what that word is. Thank you. Thank you. The answer is thank you. It's just, Lori, I could be completely wrong on a lot of things. I try to think through things logically, and that's what inspires me to want to get smarter. Is that the word for it? More knowledgeable. But you can't use the, Gus says, there's no Lori in the chat I see, because I am live on Instagram and YouTube. So a question is coming from Instagram from Lori. Gus, is this recorded? Yes. Yes, it is. So you can go back. But yes, I am live on Instagram and YouTube right now. Okay? Thank you, Justin. I appreciate that. Probably a dumb question, but is glucose measured on a blood panel the same as insulin? It is not. Insulin is an insulin level, and blood sugar, blood glucose is the glucose level. And initially, because fat cells fall first, this is how we first started this whole situation in this talk. If fat cells fall first, our blood sugar can look normal in the presence of high insulin. If the liver or the muscle cells actually fell first to insulin resistance, the blood sugars would be sky high already. But because doctors are looking only at the blood glucose level, and it's in what they call a normal level, up to 100 they can call normal. That is not normal. That is a reference range. That is an average of everybody that comes in to, but we doctors are so dumb. We'll say, oh, that's normal. You're less than 100 or you're 100. You're good. You're good. No, you're not. You're not good. A good blood sugar would be between 70 and 80, maybe even 60 in a fasting state. So, okay, there's some really good questions over here on YouTube, and I want to get to the problem. So, Lori, insulin and glucose are not the same. You need to get an insulin level, and you need to know what that in relation to what the glucose level is. Okay? Chelsea asks, here's Chelsea asking a question. What happens if a non-diabetic takes insulin shots and keeps track of sugar? Chelsea, I have had situations of people who take insulin. They do not have diabetes and they take insulin. And in that realm is the bodybuilders. Bodybuilders or figure or whatever, they take insulin because they know insulin is anabolic. They know insulin causes growth. They think it causes muscle cells to grow. So if you're Chelsea taking insulin shots and monitoring your blood sugars, so you're trying to keep your blood sugars between 70 and 80. If you dose yourself with 5 units of insulin, you know that you could eat 50 grams of carbohydrates, and you think it's only going to cause your muscle cells to grow. Untrue. Remember, fat cells fall first. So the fat cells are going to get fatter. You look at it as off season. These bodybuilders, oh, I'm just off season. I'm going to grow in the off season. I'm going to eat a whole bunch of calories, thinking calories is what's causing growth of your muscles. It is not. Insulin only tells the energy where to go, okay? And how much. If fat cells fall first, all of your insulin is pushing the energy that you consumed into the fat cells first. Once the fat cells are too full, it's going to spill over into your liver fat, and muscle fat. You bodybuilders say, my muscles are getting bigger. No, they're not. They're getting fatter. And if you recall, Chelsea, the definition of insulin resistance is hyperinsulinemia. One of the ways to get hyperinsulin or get insulin resistance is hyperinsulinemia. So now you're basically, Chelsea, causing diabetes in yourself. You're causing fatty liver disease. You're causing fatty organ disease and hyperinsulinemia. Because you're causing so much insulin resistance, now you are a diabetic. Oh, no, I'm not diabetic. Or yeah, you know what? This was going to come anyway. It's going to come because my parents are diabetic. It wasn't from your shots? Oh, no. I was just growing big and strong. Don't be dumb. Your hyperinsulinemia caused your insulin resistance, and your insulin resistance led to type 2 diabetes. All because you wanted to grow. Well, your muscles just got fatter. They're glycogen stores. They can only take so much, and then they just get fatter. The fat, ectopic fat. So your muscle cells could have been growing a little bit up to a point, and then the rest is just fat. And then when you diet down for a show, you think your muscles are just shrinking, like you've lost muscle mass. You haven't lost muscle mass. You just lost fat mass inside your muscles. Chelsea, hopefully that answers your questions. Aaron says, I would love to believe that a woman would make the changes for her baby and make changes to her food intake if educated, but people have become so selfish nowadays from what I've witnessed. I mean, it could be true, Aaron, Aaron. I mean, when it's a possibility. I mean, if you are witnessing this, then if they're actually educated, so I don't know how we would measure that. Like, how do we measure their ability? You would have to go to your doctor. The doctor would have to give you all of this information that I'm giving you in 2 hours on Saturdays and Sundays, plus all of the other reels I've been doing for the past 2 years, and answering all of your questions and answering all of the consultations, all of that. You would have to expect that woman, see, we've been led down paths that are not right. You're expecting that woman to have been told, one, by her doctor, and two, by society, that she's the actual one doing it to herself. Okay? Kashif says, what are you selling with this long speech? Please say it. I'm not selling you anything, and it's unfortunate that I would have, if I was you, I would just leave, because you're not going to be able to buy anything from me. I'm not selling anything. Cal says, it's strange thing is my blood sugar test is good, but all of the other symptoms. Check your insulin. I'm going to go down to the end. Okay. Let me see here. Lori says insulin 18.8, glucose 75. So right there, Lori, it took an insulin level of 18 to keep you at 75, to keep the 24-year-old at a 75. Whereas in an optimal person, it only takes a 1 or a 2 or a 3 to keep a blood sugar at 75. This is insulin resistant. You have a 75 blood sugar, right? And it takes 18, say, units to keep it at a 75. If you were to lower the insulin, so let's just say we took that insulin away, we went to 1 to 3, the blood glucose would be 200. Your body is trying to keep your glucose down. And it takes the pancreas pumping out more and more insulin because the cells can't take in any more. So in order to keep the blood sugar at 75, it's going to take more. But if soon, I don't know how long, maybe it's 1 year, maybe it's 6 months, maybe it's next month, maybe it's in 10 years. Eventually, your insulin will be so high, it can't keep the blood sugars down because there's nowhere for the glucose to go. You don't have any muscles. Your fat is full. The liver is full. The liver is malfunctioning. You will be straight up a diabetic. Does that make sense? But in the meantime, you've destroyed every organ. Can it be reversed? Absolutely. Absolutely. These numbers from 2 different tests around 5 months apart. I'm hoping to connect with you and pay for your guidance. Thank you. Yep, Lori, just For consultations, just email me at IronLadyDoc@AOL.com. Iron, IronLadyDoc, IronLadyDoc@AOL. Email me. We'll set up a consultation. We'll go over all of your labs, all of them. If there are insufficient labs, I'll suggest maybe getting some more labs, okay? I'll suggest getting more labs so we have as much information to go over things. I think that is important. We need baseline labs. Okay. Any other questions? Geneva has a question on thyroids. Yeah, Keith, go Dodgers, right? So yeah, a listener sent me some Dodger gear, and yeah, it's been good. So Geneva, what thyroid question do you have? I skipped most of the questions because in between all of that, I had a lot of misinformation and a lot of things, a lot of riffraff. So if you have a question, I will watch for it right now. But what is your thyroid question? I see you guys I hope, for you Blue Jay fans, I wish everybody luck. Meow Gong says, what labs? If you email me, IronLadyDoc@AOL.com, I will send you a list of pertinent labs that you can ask your doctor for. Geneva says, how does thyroid affect OOD sugars? I don't know what OOD sugars is. Help me out. Oh, are free Libre monitors accurate? A Freestyle Libre, it doesn't matter if they're, Freestyle. Okay, our Freestyle Libre monitors, okay. A continuous glucose monitor like the Freestyle Libre is a little monitor that sits on the back of your arm, and it has a tiny little fiber optic needle. You can't feel the needle at all. It measures intracellular, it doesn't measure blood glucose. It measures the blood that is in the interstitial, or it measures the glucose that's in the interstitial space. It doesn't completely measure blood glucose. So if you were to poke yourself for blood, and when your hands are warm, and you get an accurate, because even blood sugar, if you have a cold finger and prick it and check your blood sugar, it could be off. So you have to be warm, and that will give a more accurate blood sugar, okay? There's a lot of things that can throw off blood sugar measurements. But for the most part, your blood sugar glucose reading from your finger prick should be very close to the Freestyle. I would say that the Freestyle would run a little lower, unless, of course, you are exercising or you're in a sauna, your blood sugar is going to go up. Because when you increase body temperature, the body temperature in that area of your tricep causes blood flow to go to that area. And remember, you're measuring blood glucose, or in this case, interstitial. So when the artery vasodilates because you're hot, the blood sugar creeps into the interstitial space, and that is what you're measuring. So if you're cold, it's not going to be accurate. If you're too hot, it's not going to be accurate. If you're in a sauna and you're exercising, it's not going to be as accurate. But for the most part, if you want to get in a sauna, check it here, see what they are. Okay, Gabby, does that answer your question? Anton says, thank you very much, doctor, for the beautiful program, and I'm really interested in it. Thank you. If this helped you guys, share it, subscribe. If you're not already subscribed to me, please subscribe. Please, if you want to, please subscribe, okay? I don't like to force anybody to do anything. If you think there is a friend or family member or coworker who could find this information healing or help them talk to their doctor, please share it. I'm not getting paid for this. Nobody's sending me super chats right now. Nobody's donating to my cause. Kashal or whoever that was that's saying, what am I selling? I'm not selling anything. I'm doing this for free. to help you guys. That's the only thing I'm trying to do for you. Chelsea says, my husband is a type 1 diabetic with an insulin pump and a CGM. So I'm guessing maybe a Dexcom, right? You know, most of the pumps are aligned with Dexcom. So what is your question? My husband is a type 1 diabetic. You're asking is giving, your first question was, what if I'm giving insulin and I don't really need insulin? And I'm monitoring blood sugars. I'm not, what question are you really asking? So if your husband's a type 1 diabetic, he needs insulin, okay? He needs insulin or he will die. But how much insulin he needs factors in what food is he eating. If he chooses to eat a ton of carbohydrates, he's going to need his pump to give him more and more insulin, all right? If he wasn't, the pump is supposed to be accurate. If you eat a piece of bread, it's just going to give you just the amount of insulin you need to get that blood sugar back down to whatever baseline you have set for yourself. So if you set your baseline at 100, it's going to give you enough insulin to get you at 100. If you set your insulin pump to get you back down to 70, okay, could people still, that pump not work very well? Absolutely. That's why you continue to have the Dexcom or the Freestyle Libre to monitor your blood sugars. So most people, they see their blood sugars are, oh my gosh, they gave me too much, my pump gave me too much insulin, and now I better eat, my blood sugars are falling fast. I see my Dexcom, they're falling. Your thought process is, I better go eat sugar. Well, that just caused your pump to give you more insulin. So you didn't feed yourself with the right thing to feed it. You fed it now to increase your insulin. That is how type 1s get fat when they're on their pump. Okay? I mean, some people will set their pump so they'll underdose themselves so they can eat whatever they want. The diabulimia, so to speak. So they're peeing out a ton of blood sugars. They're ruining their kidneys. They're doing a whole bunch of other stuff. I mean, so Chelsea, I don't know if I answered your question or not. Tammy says, since I turned 50, I've packed on nearly 60 pounds. I haven't changed since I turned 50. So I'm guessing you're perimenopausal or menopausal. Your estrogen from the ovaries is going down. So women are very lucky. Their estrogen is like a fat burning machine. It burns fat. And overall, women, up until they're menopausal, are much healthier. They could be fatter and still be healthier. The reason being is because their fat is in different locations and estrogen is protective. Once they become menopausal, the estrogen goes down. And or even as you get older and the estrogen is still being produced by the ovaries. The fact that the insulin is high tells the ovaries not to make estrogen. That's how we started the PCOS conversation earlier. So Tammy is packing on pounds because she is lower in estrogen, higher in insulin, less sleep, less muscle, less activity, and then you pack on pounds. You might even stop eating as much. You might have changed your eating and said, they said calories in, calories out. I'm just gonna go down to 500-600 calories. I might be miserable, but I'm just gonna do it. Well, now you just shut down your metabolism, so to speak, even more, okay? So you've gone from an active kind of person to a hibernating bear. Your blood sugar might sound normal. It might be 80, 90. It might be less than 100. Your insulin level is high. You got liver fat. You got fatty organ disease. You're at risk for cognitive decline. You're at risk for diabetes. You're at risk for heart disease. All of these things you're at risk for, Tammy. And so even if you were menopausal and you lack estrogen from your ovaries, your adrenal glands should kick in and make estrogen. But they can't unless there's cholesterol on board. So if you're eating saturated fat and cholesterol, then you will make pregnenolone, and the pregnenolone will tell the adrenal glands to make DHEA, and the DHEA will make androstenedione, and androstenedione will make testosterone, and testosterone will convert to estrogen. But what doctors do and say, oh, your estrogen's low because your ovaries stop producing, not taking into consideration that the adrenal glands can make estrogen, the fat can make estrogen, even your muscles could make a little bit of estrogen. They just go, here's your estrogen in a little pellet, or here's your pill, or whatever. And it's fake. What I mean by fake, it's plant estrogen. It's a phytosterol. It's not cholesterol. We're an animal. That is a plant. Plants have phytosterols. Animals, humans, have cholesterol. It's cholesterol that helps us make our own hormones. If we go and take a plant sterol, hoping that we can raise our own, you're taking plant estrogen or plant progesterone. You're not making your own. You're shutting, now you just shut your own down. I mean, it's crazy thinking. But Tammy, I would need to analyze your other blood work. I would need to analyze your activity level, your sleep level, your mental level, all of the things that can cause hyperinsulinemia, inflammation, stress, which is cortisol, and the epinephrine, the sympathetic nervous system. All of these things would need to be taken into consideration. Okay? Your nutrition level. Maybe you're malnourished. If you're malnourished, you're getting osteoporosis or osteopenia and osteoporosis. I know it is 15 to 20 minutes behind, and the reading is also lower, Lisa says, but it gives me a 35-point under. How are blood sugars affected by thyroid? Or is it thyroid that is affected by blood sugar? Okay, you got to know which came first. B. Kundrat, I think this would require, he's asking about Lyme and fibromyalgia. I think that would probably require a consultation. That would be pretty deep to get into. Karen says, who actually can also read this info? Karen, this is public. Anybody can read it. Whether you're talking about government or anybody else, this is now public information. So people who share or ask questions maybe are not asking for themselves. They're asking for a friend or a family member or a coworker, right? Okay. That sounds like a plan, Chelsea. Stonk says, stay away from doctors. That might be the best thing. You need to do your own thing, right? Yeah. I mean, I can't recommend a doctor for you to go to, Stonks. Maybe a few that I have listened to online I could recommend, but yeah, you might absolutely be right. You need to get in a position where somebody is de-prescribing you, not prescribing you. So, in other words, stay away from a doctor. Get better on your own. Popo says, you did an amazing job, woman. I applaud you for helping so much. You're very welcome. Chelsea says, yes, I was asking if I gave it to me, would I lose weight? No, you will gain weight. If you gave yourself insulin, you would need to eat or consume energy, or else if you took insulin and did not consume energy, your blood sugar levels would drop. So if you gave yourself insulin, super physiologic dose, you will need to correspondingly give enough energy so your blood sugars don't drop. And if insulin is higher than what you need, you will drive that extra sugar into fat cells. You will get fatter, not lose weight. It'd be the opposite. How does hypothyroid affect blood sugar? Well, you would need to go into what is your hypothyroid result from. Is your hypothyroid because the pituitary didn't release enough TSH? Or if your TSH is fine, is your thyroid itself bad? Do you have antibodies to your thyroid? There's a lot, Geneva, in here that I can't answer without looking at all of the blood work. But suffice it to say, if you are a carnivore person, let's just say you're a carnivore, and you get your thyroid checked, and let's just say active T3. So our thyroid produces 100% of our T4 if it's working. And then that T4 converts to T3 in our body. The thyroid also produces about 20% of the T3. It has been shown in people who are on very low carbohydrate diets that their T3 goes down. Their active T3 goes down. And that is one of the arguments for people to go back on carbohydrates. If blood glucose goes up when eating carbohydrates and blood sugar raises T3, how do I want to ask this? Because I want you to get this, okay? How about this scenario? What if a carnivore person doesn't need as much T3? What if you got the way you got because you ate too many carbs and you decided to go carnivore and you're feeling great, but yet your T3 is low? Are you going to listen to the people that say, oh my gosh, you're going to treat your number. Oh my gosh, your T3 is low. So you either take T3 or you start adding back some blood sugar, some carbs to raise your blood sugar, which got you in the position of getting insulin resistance and type 2 diabetes and heart disease and blood pressure and cognitive decline. See, I don't see the rationale. What if that T3, even if it was low, say it's 1.0 or 0.98, you feel great, you're sleep, everything's going good, and somebody is treating a number. It's just something to think about. Gabby says, so interstitial glucose monitoring isn't the same as a fasting glucose? Well, fasting glucose is the time when you're doing it. You have fasted, not eaten, for 10 hours. That's what fasting blood sugar is. So if you go to your doctor and you get a fasting blood sugar and you check the monitor and see what it is at the minute you got the blood draw, they should be equal, but not always. Okay? If your skin was cold, that it's not going to be as accurate. It just isn't. But it's close, Gabby. It's close. It is normal to have peaks of blood sugar during the day, and your Freestyle Libre will pick it up. If you were to see, the people who don't wear the blood glucose monitors don't know that their sugar is going like this all the time. It's normal. You're just seeing it, okay? But how fast does it come down, Gabby? If it rises to 150 and then it's back down in 15 minutes, you're insulin sensitive. You're not as insulin resistant as you think you might be. That could have been, oh my gosh, I just got freaked out. I went outside, it's dark, and I heard a noise, and I got nervous. Your blood sugar, because of cortisol or stress, is going to shoot your blood sugar up. And your beeper goes off because you set it at 175 and it went up to 175, and you go, oh my gosh, I got diabetes. No, that is a normal rise in blood sugar. You do not need to treat that. You need to look in 15 minutes and go, whew, it's back down to 70. I feel relaxed. I'm back inside. I'm in safe. Okay. Do you see what I'm saying? See, people who don't have a monitor are not measuring their excursions at all. They don't even know that they're occurring. So you just happen to know that they're occurring. Chelsea, I understand your question. Your husband is good. He's a type 1. You're not diabetic. You want to take insulin to lose weight. you're going to get the opposite. If you take insulin, you're going to have to feed yourself more food. And I believe that most people would choose the wrong food to consume. They'll choose carbohydrates. It will only make you fatter. God bless you too, Geneva. Popo says, let's make all people healthy again and beautiful again. Oh no, Stonks, I'm not. You guys, your arguments are so subpar. Every so often you slip and admit I'm right about doctors. Likely, Stonks, you are right about doctors. All of them, minus a few who have tried to re-educate themselves, dumped out all of the experiences that they've been taught, empty their jar, and relearn new experiences. So if you want Stonks, to paint a broad brushstroke over all doctors, even the ones that are re-educating themselves, go ahead. If you know for a fact that your doctor is an uneducated, ignorantic buffoon, I likely will believe you. They are living in the old experiences. Okay? All right, you guys. Lucy says, this is crazy. Take insulin to lose weight. It's okay, Lucy. You're further along in your journey. You want her to exercise and change her lifestyle. I agree. Okay. All right, you guys. We will call it quits today. I apologize to YouTubers who had questions. Sined, if you want to ask that question tomorrow, I can answer it. But we've been talking for a while, and I got some things to do. I've put in, 2 hours and 10 minutes at answering questions and trying to help people. There's some extracurricular people interjecting in here. So in the future, if we're going to be on YouTube, just like the people on Instagram, I would suggest putting in a question or a cue in front of the question so I can pick it out easier. On Instagram, it's a lot easier. The print is bigger. It doesn't go as quickly, whereas on YouTube, it's going very quickly and I can't keep up. I don't have moderators. This is I'm a business of one person. I don't have anybody I have hired to monitor what you guys are saying. So for me, it's easier to ignore all the riffraff that's in between. And that is why I have missed questions. Okay. So tomorrow, I am live on Sunday tomorrow at 10 a.m. Central. Okay. So if you want to join me, I would appreciate it. If you haven't already, like, subscribe, do the clickety-clack. It helps keep this channel going. All right, you guys, have a great day. See ya.